Hello, good evening, everyone. Welcome to My IVF Answers and the European Fertility Society. We are back again this week. We are starting our webinar series. As you know, we are coming up to a very big milestone for us, as our 500th webinar is coming. And actually, tomorrow, this is our grand, I would say, achievement, I think. And of course, we are very happy and we are very we cannot wait for this event to be here, of course. But we are also excited to be here with Dr. Alexandra Eissler. You can see her right here. This is her first webinar with us here on the English platform because she already had a chance to participate in a German webinar. So I'm glad that you are joining our English webinars as well. And today we will talk about failed cycles, miscarriages, and of course, Dr. Alexandra has a presentation on this, and she will walk you through all the steps that can be taken and what can be done if something like this happens to you. And of course, afterwards, there will be time for your questions. So as always, don't hesitate, put the questions in the chat section. Dr. Eissler is here for you, simply to help you out with any questions you might have. And let me just remind everyone that Dr. Alexandra Eissler is the specialist, fertility specialist at IVF-Life in Alicante. Thank you so much for joining us today. I'm really looking forward to what you have prepared today and to what we will discuss today. This is definitely a not an easy topic. So thank you everyone also for joining, but I always remind everyone that remember, we are here for you. And if there are any questions that you would like to ask, remember, it's all anonymous, but it's also recorded. So of course, if anyone, I hope not, if anyone need to leave, of course, you will be able to rewatch this as it will be available on our website tomorrow. So I guess we can start with our presentation. Dr. Eissler, thank you so much again. How are you? Hope you are feeling ready and are ready just to simply start our event.
Yes. Thank you very much for the kind words and the introduction. I'm very, very happy. Welcome to everybody. I'm glad to be here tonight and to be able to talk with you about the topic. And the topic of tonight is the question: what to do with failed cycles and miscarriages. So that's a very important and very emotional topic. I am very, very grateful that we have the time here to discuss this theme a little bit more in detail. Yeah, I'm pretty sure that a lot of patients unfortunately have to go this way, and at one point of the treatment they arrive at the situation that they have to ask themselves the question: what to do, how to proceed, have I done everything right now? And maybe there are also some patients among you that are already asking yourself the same question. So of course, it's a very, very, very emotional and very, very difficult question, how to go on. And the most important thing is that each patient and each case is a very, very unique case. And of course, we have to consider everything very individually. And of course, there are some protocols and some guidelines that we can follow, but in the end, every case is an individual case, and we have to find the best solution for this special case. So the keywords are person-related diagnostics and, of course, also person-related treatments. So what can we do in such a case? What can we offer? So it's very, very important for us before we start any kind of treatment that we try to find out what is the cause, what is the issue, what is the problem about the infertility, why are these miscarriages happening, why is there no implantation, why are the problems there? And this is something we want to find out before we go for another treatment, because of course there might already be a lot of other treatments done that you have done before in other clinics, and of course we can learn from these treatments you've done before, and we can learn from every failed cycle, we can learn from every failed implantation, we can learn from every miscarriage, but we have to study them, we have to go behind the protocols and to see what has happened, what was going on. And that's why we ask, why does it fail? There are a lot of different reasons for failing. The most important ones are the egg quality, that there maybe still are eggs that we can use, but the quality of them is not good enough. Second thing that we can check is the lining. The lining is a very, very sensitive area. It's a very often changing area of the body. So every month when you're bleeding, you're losing the lining, and it has to be rebuilt every month, every cycle. So on the one hand side, it's a very unstable tissue, and on the other hand side, we have the egg, the embryo, and the sperm. They perform the embryo, and the embryo tries to implant. But of course, there's always a little bit of foreign material in this embryo that is not from your body, either from the partner or from an egg donor. So of course, the body has some special security mechanisms that are in the lining to make sure what is going to implant, what not. And then there's the male factor, also very important factor, also very important in terms of failure of treatment, because also here can be issues, problems that are as important as the other two reasons. And then there are some other reasons. I will explain them later. Let's have a look at the egg quality. So what are we talking about when we talk about the egg as an issue of the treatment, as a failure possibility? So of course we need enough eggs. So as you all might know, the ovarian reserve is going down with the years, with the age. So, and it's also very individual. So this is something we have to consider well and to check before we start any kind of treatment to make sure, do we have enough eggs? How is the reserve? What kind of doses of medication do we need for this kind of reserve, for this number of eggs? Then there's the AMH, the anti-Mullerian hormone, that we have to measure in the blood to see how is the expectation of this ovarian reserve, because we know from research, from studies, that the AMH level is very well corresponding to the ovarian reserve. And then there's the antral follicle count. That means that your gynecologist or we or the fertility clinic next door are counting the follicles in a scan, and then referring to this number, we can also get an idea how does a cycle look like. And of course, as I already told you, the age is also an important factor, not only for the number of the eggs, also for the quality of the eggs. Because of course, the older a patient gets, the higher is the risk that the embryos in the end don't have the right number of chromosomes, that the children might get a syndrome like Down syndrome, trisomy 21, the most common one. So we have to make sure that the risk is not too high, or maybe we can go for any genetical test before. So here are some options what we can do to solve these issues and to better the possibilities in terms of egg quality. So first thing, we can individually see if the patient needs any kind of priming. Maybe there's an issue in offering the right number of eggs, they need a little bit more time. Then, as I told you about the the right number of chromosomes. So if the embryo is euploid or not. So if the embryo in the end has the right number of chromosomes, we call it an euploid embryo. And this is something we can test. So we have to fertilize the eggs and to develop them until day 5. And then we can go for the pre-implantation genetic testing of the embryos. There's the PGTA testing of euploidy, what means that we see if the embryo is euploid, so that it has the right number of chromosomes, or if it's uneuploid, what means that it doesn't have the right number of chromosomes. And then there are some further tests, pre-implantation genetic tests that are for specific illnesses that are already known in your family, for example. Then, of course, we go for a very personalized stimulation protocol. As I told you earlier, we check the earlier stimulations you had done in other centers or even in our center, and we make sure that we learn from them. So we see what happened, what kind of medication, how was the doses, how many eggs did you get, got they easily fertilized, was there the problem, was the problem more in the development and the activation of the sperm. So there are a lot of things that we can have a look at and what we can learn from. Another option to better the quality of the ovarian reserve, so in terms of number, but also the egg quality, so in terms of quality, is the PRP. This is something we use in our clinic since a few years. It's a very new method, a new possibility to get a little bit better results on stimulations. PRP means blood-rich plasma, what means that we take out a blood sample of your own blood and we extract the blood platelets. And in these platelets, there is the growth factor, what we can re-inject in the ovaries. And this growth factor is making that the cells are dividing a little bit faster, what means that we can, through this method, we can maybe gain a little bit more possibility of better quality of the eggs and sometimes also a higher number. It's a very, very new possibility of treatment, a new treatment, what we're using in our clinic, but it's also used in other clinics. And we've seen very, very good results. So it's not a total game changer, but it might better the quality and also the quantity of the eggs. Yeah, and in the end, we have, of course, to decide, is IVF the right treatment, or do we maybe have to think about egg donation for the patient, and what are the advantages and the disadvantages, and yeah, individually see with the patient together what is the best way, what is the best treatment, and also what is the goal of the treatment. Second point is the lining, the endometrium. So there are several things, as I told you earlier, it's a very, very often changing tissue, and there are several things that we can check and what we can also use to better our chances. So what we can do here is we test the implantation window. The implantation window is the time that the lining needs to be prepared with progesterone. So normally in the most women, in 70% more or less, it's 5.5 days of progesterone. But there are also a lot of women in whom the window changed. So there are sometimes there is a reason for a change, sometimes we cannot find a reason. But for example, miscarriages, earlier pregnancies can change the window of implantation. And this is exactly the time window when the lining is the most receptive for the implantation, for the embryo. And of course, we want to use this window. And then there is the immunology, what is a very, very huge part, and gets more and more important the last years, also for the implantation. as I told you, the lining is changing, and there are some security mechanisms that are provided from the body. For example, the natural killer cells, the T helper cells, and there are some ratios between them that we have to consider well. And if there's an issue about them, then we can treat it. Then we can add some medication for your transfer cycle, to make sure that this is not making the implantation more difficult. Yeah, and then we can test for endometriosis, what means chronic inflammation of the lining of the endometrium. What might be bacterial but don't have to be bacterial. So we also look for bacteria that shouldn't be there. And these are things that we can treat with antibiotics, for example. And how do we find out about all this? This we find out by endometrial biopsy. So that means that we go inside your womb vaginally, and we go inside with a biopsy catheter. What is a very, very thin catheter? And we aspirate a little bit of your lining. So this is normally there's no anesthesia required. The most women feel that the catheter is going inside the womb, and also during the biopsy you might have a little bit of pain or period cramping, but normally there's no need for an anesthesia. But also this is very individually. Some women feel it more, others feel it less. So it can also be done in anesthesia, but normally we do it here in our consulting room. Very, very easy procedure. Yeah, and we take out a little bit of the tissue to analyze it after the preparation, of course, of the lining, because we need to prepare the lining as if we would transfer an embryo, but instead of the transfer, we go for the biopsy. And this is called RMAP and EMAP. These are the two different tests, one for the window of implantation and the other one for the immunology. And then we also check the CD 138 for the inflammation and some other parameters. Yeah, and if a lot of cycles failed, and in some cases we might also consider to go a little bit further and test for receptors, the KIR, and also the HLA-C genotyping. But this is also for special cases and has to be considered individually. Let's have a look at the male factor. Yeah, the male factor is the sperm quality, of course, and there can also be a lot of different issues. So I only put a few diagnoses here, what can result from a spermiogram. But yeah, so to say it in easier words, there can be too less sperm cells in the sample, then they can be less mobile. Then usually they can have abnormal forms, so that it might be difficult to find sperm cells with normal forms. And it can also happen that there are no sperm cells in the ejaculate, so in the sperm sample. And then we have to consider why. Is it an obstructive reason, or is there any other kind of reason? And yeah, those are the things that we can see directly in the sperm sample. And then we also have a look at the sperm DNA fragmentation to see if there's any problem in terms of destruction of the DNA. And we also have a look at the apoptosis, so how many of the sperm cells are killing themselves afterwards. And there are a lot of different mechanisms how we can influence also the quality of the sperm. Of course, we can give you some medication, some vitamins that you can take, and then we take another sample. Or once we have the sample, we can extract the good ones with some mechanisms. For example, mechanical ones, magnetic ones, temperature-based ones, and chemical-based ones. And if all of this is not helping, to get the best sperm cells. Then there's still the teaser, what is possible. That the teaser is a puncture of the testicle. And by this puncture, it's possible to get best quality sperm cells, because sometimes during the way that they have to pass to go out of the testicle, so the urethra, they get in touch with oxidative stress, for example, with the air, with urine, and during this way, this can also damage the sperm. So the teaser might be a good option, or of course, if there's any obstructive obstacle, so that the sperm cannot pass easily. Yeah, and then last but not least, once we have the best sperm samples, best sperm cells that we can get, the technique is very important of the fertilization, and there are also different techniques. Of course, there's the normal IVF and the ICSI, but there are also IMSI or PICSI. So this is in the end the work of the laboratory to decide what is the best way to fertilize the eggs with this sperm. And I told you earlier, there are some other reasons, other causes that can cause miscarriages, implantation failure, or failure of cycles. So we have a look at a lot of different other things before we start treatment. So it might be necessary that we look at your karyotype, that is an imaging of your chromosomes, so that we see how are the chromosomes, not only the number of chromosomes, but also sometimes they can change a part of arm, for example, so translocations. And pregnancy in general is depending on the quality of the egg, of the sperm, so the genetical part, but also on the immunology, what I told you earlier, the immunology of the lining, but there are also some immunology parts that we can measure in the blood, for example. We can see how is the thyroid equilibrated, or are there any issues about your thyroid? Are the thyroid levels in the good range, or do we have to treat them? Are there any autoimmune diagnoses that we have to consider? So those are examinations that we can do here. And the other very important thing is how is the blood coagulation, the risk of thrombosis, because we know from research that miscarriages can also be caused by microthrombosis in the placenta. So we want to make sure that you don't have a higher risk as usual as women in general. So women in general have a higher risk than men. And during hormonal substitution or pregnancy, so all situations in life where you have a higher level of hormones, what is also the case in a normal pregnancy, or during, of course, hormonal therapy. So in these cases, the risks are even higher to develop thrombosis, and this is something, of course, we want to include before we start any kind of treatment, so that we don't have this problem in the end when we transfer the embryo. So these are all things that we can have a look at before we start the treatment to make sure that we find the best individual treatment for you. And yeah, so we start normally with the ovarian stimulation or with the preparation for the transfer, depending on, of course, what is the treatment, the selected treatment, if it's an IVF cycle, if it's an ectonation cycle. Yeah, and then we help you with the medication, with the dosages, with the dates, what you have to take when, and this is really very, very individual. And this, of course, according to the results of the tests, of the diagnoses, and of what we learned from earlier cycles that might have already taken place. Then once we have the embryos, we go for the embryo transfer, what also needs a very specific preparation. And here it might be necessary that we go for the endometrial biopsy that we can do in the mock cycle, but in any case, we would go for a mock cycle to see first how is the lining responding to our medication, or to the hormones that we give you. Is it growing well? That we can make sure that later in the transfer cycle we have the best conditions for the embryo. And of course we stay with our patients until the end of the first trimester. So we follow up, and after the transfer we are still on your side. So according to the progesterone levels, the immunology part, the analysis, we tell you what you have to take after the transfer, what kind of medication, how long you have to take it, and we are still there for any kind of questions and issues, of course. And of course, we are still we are always happy to be on your side even longer, and to get also then the information that you happy delivered afterwards. So how does it work? How does the treatment start? How do we get you? Can you get in touch with us? So of course, there's the first contact, that we have a talk, that we get all the information, what we need, and then we will plan the first consultation. The first consultation, we need information about further treatments, your medical history, medications you might take. There are a lot of different things that we have to talk through in the initial consultation, that we can explain you what is the recommended treatment, and what kind of medication, what doses would be the best for you. And then we can create together with you a plan with dates, timelines, that what does it mean for you? How often do you have to come here? How often do you have to take medication? How long does it take? All of this is very important as well, because you have to plan your life. And then once we have the embryo, we can prepare the transfer. And as I told you earlier, normally we go for a mock cycle before we go for the transfer. And also here might be some additional examinations necessary. Then we go for the transfer itself. What is a very, very beautiful, special moment. It doesn't take that long. So normally it's half a day, not even half a day in our clinic. But we recommend always to be here maybe the day before and to leave the day after if it's possible, and to avoid stress. I mean, it's also possible to do it in a one-day trip, but my recommendation would be to stay here for at least 2 nights to make sure that you don't have to hustle, and you don't have to come here running from the airport, for example. And then of course we are happy to get all the results, and to be on your side for the first weeks of the pregnancy, and for the follow-up after the treatment, of course. So you see, in general, we can say the treatment, and also the analysis of the cycles is very, very individual, and has to be really made specifically for every case, and to see what is the reason why did the cycle fail, why did the miscarriage happen, why did the implantation fail, to make it better afterwards, and to find the reason first, to treat the reason before starting a new treatment, a new try. And I'm now at the end of my presentation. I'm looking forward to your questions, and thank you very much for your attention.
Thank you so much indeed for your presentation and walking us all through all the steps and, of course, providing all the details. Now, as you can see, lots of questions are ready. So let's get going with them. And remember, if you wish to ask something, this is your time. Go ahead, type this in. As I mentioned, some of the questions are ready and some of them are really interesting. So let's have a look at the first question. I had a chemical pregnancy after my first cycle. Is there anything that I can do to prevent this in following cycles? Anything which can be done to help implantation?
Yes, I mean, a chemical pregnancy is already the sign that there was a reaction of the body on the transfer. So there is something that we can see, that we can measure. And of course, now we have to see if there have there been any other pregnancies in your life? Is there anything what happened before? So we have to see how's the medical history, how does the womb look like, how does the lining look like, how did it look before the transfer? And yeah, in this case, it's a good idea, for example, to go for the endometrial biopsy if it hadn't had place before, to see if there's an issue about the immunology, if there's something that can be treated, what was not treated before for the first transfer.
Okay, thank you so much for your advice. So there are many things that that need to be checked, of course. So remember that it's hard to give just a direct answer here, and I know that Dr. Eissler definitely would need more details. And so, of course, still thank you so much for this question. I hope that helped. But of course, if you have more follow-ups, you know what to do. But also, you can always get in touch with the team at IVF-Life. I'm sure they will be able to help you out. And actually, there is a follow-up. So let me go straight to this one just in case. So is there any treatment protocol to improve number of eggs? It's the same patient.
Yeah.
Obviously.
Also, this is very individual question, and it's hard to answer without knowing the specific case. Yeah, so there are a lot of there are some options to better the number of eggs, but yeah, in general, this has to be overviewed in the specific case.
Okay, thank you so much indeed for that. Let's have a look. More questions are coming in. So if you go to a clinic and they just have one protocol, should we not attend there, I guess, yeah, anymore, I believe.
Yes, I mean, if there's the same protocol for every patient, of course, in my eyes, it's not very individual and helpful. I mean, this can work for one patient, but it doesn't mean that it has to work for the next patient as well.
Okay, that makes sense, of course. And I will go to this question straight away. So, what oxidants, or vitamins are given for DNA fragmentation?
So normally we give T, what is a medication, what is also helping in this case to better a little bit the quality of sperm, and also vitamin E, A, oxalina E is very helpful here.
All right, thank you so much. And actually, now we will go to a few questions. I will read just the first one because there are a few questions in one. So is there any possibility to convert primordial follicles into antral follicles?
Also, this has to be seen. So every cycle is different. So this is depending on the cycle, what we can do here, what kind of medication we can give here, and how we cannot change, we cannot do anything specifically on one follicle, for example, to make it changing. But we can consider the medication well, we can consider the dose as well to get the best number of antral follicles.
All right. Thank you. And let's have a look at the second question. So, what does a very low testosterone level mean? So, and in the meantime, is there any connection between cholesterol, aldosterone, cortisol, and testosterone?
Is it? I am not sure if this question is referring to the testosterone level of a man or of a woman. Of course, you always have to consider all the hormone levels at once. So what we there are some connections, yes, but the most important hormones for the ovarian stimulations, for example, for us is the estrogen and the progesterone level, and also the FSH and the LH level.
Okay, if you can clarify if you mean something else also by that, and of course let us know. Write this in the chat, okay? And yeah, because as you can see, yeah, what if every single of them is too high, too low? Is this the reason for failed IVFs? Can be.
Okay, so yeah, I think we're talking about the testosterone in women. And yeah, as I said, of course, the most important hormone levels are estrogen, progesterone, LH, and FSH. And if this is the reason for the failed IVF, is also something that has to be considered or just has to be seen very specifically to knowing the whole simulation. By just knowing one hormone level, it's hard to say this is the reason because it failed. It's impossible to say.
Okay, that's understandable again, of course. And let's have a look. We have some details when it comes to the next question. So let's have a look. You mentioned that in transfer cycles, most women need 5.5 days progesterone. My clinic has recently started to use only 4 full days progesterone and transfer on 5th day medicated cycle. I have frozen embryo transfer coming up with my final embryo, and I am really worried about only using 4 days. Many people seem to be having success with this 4 days. I know the era isn't a reliable, but I had it a few years ago and was receptive at 5 days. Should I request 5 days progesterone
You had
medicated?
the ERA test done, and you were very receptive in at 5 days. Then that means that you need 5 days of progesterone for the best receptivity of your lining. In this case, I would discuss it again with your clinic and with your with your doctors that are in charge of you. But yeah, normally then you should have 5 full days of progesterone. And yeah, but you have to calculate the days well. So that until the start of the progesterone, until the transfer, it's 5 days.
Okay, and actually there is a question here. Let's go ahead with this. So does 5.5 days of progesterone mean doing the transfer in the afternoon on day 6 of progesterone?
It depends when you started the progesterone. So it means that from the start of the progesterone until the transfer, there should be 5.5 days.
Okay. Thank you. I think it's a little bit clearer now, of course, and sometimes it can be quite confusing. So thank you so much for that. Okay, and what are your thoughts on diets, lifestyle changes to improve in sperm health apart from antioxidants?
Yeah, so I think there is an influence on the egg and the sperm quality of the lifestyle. So what means in terms of healthy lifestyle, in terms of regular activity. You don't have to be you don't have to go for a marathon every day, but a normal moderate physical activity every day, half an hour, is very helpful. A diet in terms of healthy nutrition is important. And of course, you have to consider all the other factors, the age and the ovarian reserve, the AMH level, what are, in my eyes, more relating to the outcome of a cycle. But it's very helpful to have a healthy lifestyle, a moderate physical activation, and in terms of sperm quality, also regular ejaculations can help to get the production of the sperm cells a little bit higher.
Okay. Thank you, Sandra, for your question. And let's have a look. Emily would like to also know, so what are your thoughts on MTHFR mutation? Does having it mean you have more risk of recurrent implantation failure?
It does not has to mean it directly. So there are a lot of different mutations here that you can have in combination, for example. And of course, there's the opinion also required of a specialist of genetical specialist. What this means exactly for you, but it might be that you have to prevent to prevent and to add some medication for the transfer cycle to make sure that you don't go for an implantation failure. And with this medication, you have the normal risks and also the normal possibilities of success.
Okay. Thank you. More questions. There are more questions ready, but of course, if you have anything else, go ahead, type this in. There are like 3 of those done, so left, sorry. So if you have more, you know what to do. We still have time for you. So let's have a look at this question. I've had 8 IVF cycles, 1 miscarriage, and some fertilization failures. I have low AMH AFC of 6-7, stage 3 endometriosis. Have you seen good results with someone like me?
Yes, I mean, this is depending on how low is the AMH level. The follicle count of 6 to 7 is not that bad. Of course, stage 3 endometriosis is an issue, is a problem, because we know that endometriosis can be the reason of lower egg quality. But I have seen cases, of course, I'm answering without knowing the AMH level, but there are cases that are successful. But it's always, with endometriosis, it's always a little bit more difficult.
Thank you, Lynn. I hope that helped you a little bit, of course. But as we always say here, right, it's important to stay positive and try, of course, as well. And now we will go to the next question that we have from Joseph. So what should the ideal progesterone level be on day of embryo transfer? What form of progesterone is best? Tablet, injectable, patch, or pessary?
So normally we use Progesterone, what is taken vaginally, but it's also depending on the level and on the person. So there are also women that don't respond well on the vaginal progesterone. So then in this case we have to change for another form and to find out what is the best for this specific patient. And in our clinic, we consider the progesterone level as well if it's 10 or higher the day of the transfer. But this is depending also on the clinic. So I know there are other clinics with other progesterone levels, but in our cases, considering well the research that is already done, we defined the number for the level of 10 as good.
Okay. I believe that was, again, useful. Thank you. And we will go back to the previous patient, okay, because she has actually provided the AMH level. So it's 5 picomoles per liter, right? So it's 5 picomoles per liter. It's from the previous patient. Anything you can add?
It's very corresponding to the antral follicle count in my eyes, so I'm not surprised. And I stayed with my earlier answer to this question, that I've seen cases that are successful, but yeah, it's normal that the way might be a little bit longer.
Okay. Thank you. And we will go back again. There's a follow-up. So sorry for the level of progesterone you mentioned, 10. What are the units?
And the units of the progesterone, this is also, of course, depending on the clinic, which progesterone units
Of course.
are used. And this can be very very different in each clinic if it's nanogram or per milliliter, for example. And yeah, so in our clinic we use the 10 nanogram per milliliter.
Mm-hmm. Okay. Thank you. I believe it now has been cleared. And there's one more follow-up, okay? So if you can have a look, this is a follow-up from previous question, if you can have a look at this. So if I start progesterone in the morning of 20th of November and frozen transfer is scheduled for the 25th, what would be 5.5 days in that case?
Sorry. When you start the progesterone in the morning of the 20th of November, and then the frozen transfer is scheduled for the 25th. So in the morning of the 20th, then the 21st, it's one full day, the 22nd, second full day, 23rd, third full day, 24th, fourth full day, and 25th, the fifth full day in the morning. So 5.5 days would be in the afternoon time or in the night time, yeah, depending on the hour of when you started the progesterone level. But yeah, if you started at 9 o'clock in the morning, it would be 9 o'clock in the night, the 25th.
Okay, I think that now it's more clear. Thank you so much for your follow-up and your help with that. Okay, and let's have a look at the next question here. Yeah, and there's a thank you from our patient for you for explaining this. Now it's clear. So let's have a look at another question. So I had 4 transfers. Out of them, 2 were miscarriages. I have few more embryos left in the freezer. But is there a point going with frozen one, or start a new cycle and create new embryos?
Also, this question is very, very individual and has to be is depending on a lot of different things. So you had 4 transfers and 2 were miscarriages, and there are some embryos left in the freezer. But yeah, it has to be considered what examinations had been done before. Is there something that can be changed, that can be learned out of the four transfers you had on the miscarriages? What was the reason? What was the quality of the embryos? What is the medical history? So there's a lot of things that have to be really verified in a medical consultation before I can properly answer to this question.
That's understandable. As always, you need more details in order to be able to properly answer. And possibly our final question. So if you have more, this will be the final call for them. And yeah, there are some more, but let's have a look at this one. So hi, can PGT testing be done on frozen embryos? Does this affect the embryos?
So normally we do the PGT testing in day 5. At day 5, the embryo is called blastocyst and has an outer cell mass and an inner cell mass. It's very well defined and has more than 120 cells. And what we do is that we do a biopsy, or the laboratory is doing the biopsy on the outer cell mass of the embryo, and is taking out a few cells. So it's a small biopsy on the embryo. And in the research, it was shown that in the most cases, the embryo is not is surviving this very, very well. And so what we know also from children that are born with PGT-A testing, for example, this is not affecting children in general. So what we know from the research right now, that in the most cases the embryos don't be affected in terms of quality, for example. And PGTA testing can be done on frozen embryos. So we can defreeze the embryos. You have to defreeze the embryos, but you can refreeze them afterwards, for example. But you have to refreeze them, and we have to defreeze them to do the PGTA testing and to refreeze them afterwards. But it's possible.
Okay, and I will go to the follow-up question. So PGT is usually done before cryopreservation. Is it advantageous or dangerous to the embryos? Are the blastocysts better collapsed or not?
I'm sorry, I don't understand the second part. It's in general, it's not dangerous for the embryos. So, so far we know right now they're PGTA, and we do a lot of PGTA cycles. As I said earlier, the quality of the embryo is not getting lower, for example, through the PGTA testing. And I don't get the second question. Are the blastocysts better collapsed or not?
Yeah, so let us know what you mean exactly by that, okay? I'm not sure here as well, so it's better to double check. So if you could type this in, we will go back to this question, okay? All right, let's have a look. We have a follow-up from our previous patient as well. So I have had failed implantation. I had a hysteroscopy, was put on Lupron downregulation for 3 months. The doctor wants to proceed with prepping me for frozen embryo transfer without bleed. Is that right?
Also, in this case, you have to know more details about the failed implantation. In general, it's not a bad thing to go for an hysteroscopy to see what is happening. And also the downregulation, it's important to know why, what are the reasons, and what are the circumstances, to answer these questions.
Okay, and again, thank you so much for that. And might have been our final question. And of course, thank you so much, everyone, for your questions. And as always, if you wish to get some more details from Dr. Eissler, her team at IVF-Life, I'm sure they will be happy to give you some proper answers. As always, they need more information. But I think that it was a very interesting session already. And thank you, everyone, for joining and staying with us as well. And Dr. Eissler, it was great to have you. And anything? Okay, sorry, one more. Okay, because there is a explanation from Joseph, so I think we can still take a look at it. So, I mean, do the blastocysts recover better for frozen embryo transfer if collapsed or not? Do they recover better?
I think it's concerning on the PGTA. So
yes, sorry, yeah.
So normally, if when you defreeze the embryo, they are not collapsing. So and also the PGTA doesn't make them collapse, so they should not collapse.
Okay, Joseph, let us know if that's clear, and I think that that will be our final question. But let us know, okay, if that answers your question. I believe so. But of course, thank you so much, everyone. And I just want to add that I would like to simply ask you, as we've done it before, but before we finish, if you can have a few minutes and just simply let us know what kind of topics you wish we discuss. As you know, there are plenty of topics we already discussed during this year, but also previous years. But we are always happy to perhaps explore some other topics that we didn't think about. So if there are some topics you you think that we could still discuss, let us know. Type this in the chat as well if you wish, and we'll be happy to take a look at those as well. Or you can simply email me. That will be always possible. As you know, my email address is in the chat, but just in case, it is caroline@europeanfertilitysociety.com. So if there's anything you wish to share with us, go ahead and do it. We'll be happy to take that into consideration for sure. As you know, we are here for you. Okay, thank you. I will make a note of that as I see one of the answers in the chat, responsive uterine lining. Okay, thank you so much for sharing. And as I mentioned, if you wish to share some more, you can still get in touch with me. That will be it for today. But before, again, we finish, I wish to say once again, thank you so much for joining, and also invite you, everyone, for our webinar tomorrow, as this will be actually our 500th webinar with Dr. Esther Marban. We will discuss fertility treatments for women over 40. So if this is something that you think might be helpful for you, join us. It's going to be a great session, I'm sure. Thank you so much, Dr. Eissler, for joining. Before we finish, is there anything else you wish to add?
No, so thank you very much for the questions. They were very helpful. I mean, in general, sometimes it's very difficult to ask to very individual questions, because, of course, as I told you earlier, it's very, very important to know the whole case and to know what kind of treatments were done before, and what are the things that already happened, and why did they happen, and to see the case in the whole story of the case. So I'm sorry that I couldn't answer all the questions and the detailed questions about your cases. Sometimes it's very important to know the whole history. But yeah, thank you for all the questions you had, and thank you for having the possibility here, of course.
Thank you so much. I'm looking forward to some more events coming up with you as well. So thank you so much indeed. And this was a great session for sure. Take care, everyone. I hope to see you tomorrow. Dr. Eissler, a pleasure. See you soon as well. Take care.
See you.
Bye.
Bye-bye.